We have Dr. Madhuri Manchu. She's consultant in fetal medicine at Medicover Women and Child Hospital in Vizag, ultrasound and prenatal genetics, and is accredited by the FMF. She has 3 publications in international journals, and she has been a faculty in state and national conferences and also conducted workshops and teaching programs to PGs. So I extend a warm welcome to Dr. Madhuri. Please go on.
Gynec Society for giving me this opportunity. My topic is on ultrasound in predicting mode of delivery and labor outcomes. First of all, do we need to do ultrasound to predict this? Why do we need to do ultrasound to predict actually? Because though I keep doing only scans, every day I keep listening to these questions from the patients. Is the baby's head down? Will I deliver normally? How much more time will it take to get pains? And so on. And even in the labor room, we hear these dilemmas from the obstetrician. Is it OP, occipito-posterior? Is the rotation over? Is it deflexed? Why is it taking so long? Will it come with the instrument, or is it better to go for cesarean straight away? So there are many dilemmas, and we'll see how ultrasound helps in this aspect. So in the clinical examination, you will be seeing all these things: presentation, position, how much of head is palpable, your Bishop score, pelvic examination for adequacy, and in the labor, caput, moulding, sutures and all. The same things you will be seeing even in the ultrasound examination: presentation, head position, engagement, entry into the maternal pelvis, and then there is this ultrasound scoring system for this, and we'll see how to evaluate in labor. There are 3 modalities of ultrasound, and which one to choose. Basically, if you want to know head position and attitude, it is by transabdominal scan, and transvaginal scan is purely for cervix parameters. Transperineal scan is basically for head station, head direction of descent and rotation, and the cephalic malpresentations. So much of the work during labor we do by transperineal ultrasound. So coming to transabdominal scan, you can put the probe either horizontally or vertically. So when you are doing transabdominal scan, initially you need to put the probe horizontally on the suprapubic area. Then if you are seeing a midline like this, horizontally, it is occipito-transverse. And if you are seeing orbits at the same place, it is occipito-posterior. If you are seeing a midline which is vertically down, then it is occipito-anterior. And if you rotate the probe here, you will be seeing occiput and the spine. So that is the occipito-anterior. Now, always baby's head won't be in strict horizontal or strict vertical. So when it is not like that, you have to consider the occiput in a clock phase. So whenever the occiput is between 2:30 to 3:30, we take it as LOT. Whenever it is between 8:30 to 9:30, we take it as ROT. Anything above this is occipito-anterior, and anything below this is occipito-posterior. So sometimes when the head is very low down, you need to do a transperineal ultrasound. See, in the first picture, you are seeing the midline horizontally. So it is an occipito-transverse position. And in the second picture, you are seeing the midline straightly. So in this case, how do we know which side is the occiput? To which side the choroid plexus is diverging, and to which side the head is broad, that side is the occiput. Then how do we know how proximal the head is to the maternal pelvis, and how much has entered into the maternal pelvis, and did the head engage? So for this we need to ask ourselves set of questions. Am I getting a good BPD plane in the first place when you are putting the probe on the just above the symphysis pubis? If you are not getting a good BPD plane, it means that head might have already entered into the hollow of the pelvis, or sometimes you might have to angulate the probe carefully to get the BPD plane, meaning the head is in alignment with the pelvic inlet. Sometimes you won't get the head when you are putting the probe on the suprapubic area. You need to go upwards. So head is above the pelvic inlet, and there are obstetric conjugate and suprapubic descent angle which helps in these things. So this is what is obstetric conjugate. You are seeing the distance between the pubic symphysis and the sacral promontory. You are seeing two bright spots here, and the line between the pubic symphysis and the sacral promontory is the obstetric conjugate. So here you are seeing the obstetric conjugate, and the head has just started crossing this line. Here the head is well above the obstetric conjugate, and also it is floating head. So means the head is much anterior above the level of symphysis pubis. See, here the head has just started entering under the pubic symphysis. Here much of the head has already gone beyond the symphysis pubis level. When I say this asynclitism, it may sound funny, but believe me, in ultrasound it is easy to identify. In clinical examination it takes a lot of expertise, but in ultrasound it's easy to diagnose. So what is happening in asynclitism? A midline echo, which is supposed to be seen horizontally, will be deviated either anteriorly or posteriorly like this. So here you will be seeing a part of thalamus, and a part of thalamus is not visible. Here you will be seeing a part of cerebellum, and a part of cerebellum is not visible. So when I am putting the probe on the suprapubic area, I am not getting a good BPD plane. But if I am going that far, almost near the level of umbilicus, and angulating the probe, then I started getting the midline and arrow. So this is one way of identifying asynclitism. Look at the contour of the presenting part. It is so sharp, irregular. So again, this is a feature of asynclitism. More about this we'll see during labor. So you, as an obstetrician, if the patient wants to know her chances of normal delivery, you tell by Bishop score. So we started telling it by an ultrasound score. For this we did a study in our unit, and the study is prediction of mode of delivery by an ultrasound score similar to Bishop score and the performance of independent predictors. So the key messages in this article is that out of all the parameters which we have studied, cervix length is a best parameter to predict success of induction of labor or spontaneous onset of labor, and this ultrasound scoring performs as good as or even better than Bishop score. So we have taken certain analogous parameters as we have taken in Bishop score. We have taken head station, cervical canal diameter, cervical gland hypoechogenicity, cervix position by its relation to symphysis pubis, and cervix length. Now when I am telling all these terms, it might appear as though it is a big time consuming scan, but believe me, this single mid-sagittal transperineal image gives much of this information. It is like an NT scan image. One single NT picture gives lot of information. Like that, a single mid-sagittal transperineal image gives most of this information. It's not time consuming, it doesn't need a lot of expertise, it doesn't need high-end machines. It can be done n number of times because it's not painful to the patient, and then it helps in documentation and objectifying also. So this is the scoring system which we did with the ultrasound parameters, and these are the pictures of progressive head stations at various levels, and this is how we measure the cervix length. This is a cervical gland hypoechogenicity, which corresponds to the cervix consistency, whether it is soft, medium or hard, and this is a cervical canal diameter. So in the first place, how to do a transperineal ultrasound? You need to put the probe like this. When you're putting the probe like this, you will get a picture like this. So I have depicted the landmarks in color. This symphysis pubis is in yellow, and the blue line is the capsule of the symphysis pubis. The green line is the urethra, and the another green line is the anal mucosa. This is the leading edge of the fetal skull. Now, the main purpose of doing transperineal ultrasound is head station.
Call it as AOP. So, according to the AOP, if the AOP is around 120 degrees 160, it is zero station. But this study is done in the Western literature, and they measure pelvis differently in centimeters. But we do pelvic examination in 1/3. So, I have done that mathematical calculation, and I have derived AOPs which correspond to our pelvic examination. So this is -3, -2, -1 and 0. So if you look at a glass, you need not even measure angles. If the head is above the level of pubic symphysis, it corresponds roughly to -3. If it is almost to the level of pubic symphysis, it is -2. And if it has crossed the level of pubic symphysis, it is -1. And if it has crossed at least by 3 centimeters, it is zero station, and it means that head has already engaged. So when it is 135 or so, it is +1. When it is 145 degrees, it is +2. So if you feel this AOP is doing is cumbersome, you can teach your assistants or labor room sisters. They can do this head perineal distance. This is how to put the probe, and you need to apply pressure. Compress the soft tissue structures. Then you will get the minimal distance between the head and the perineum. So if the head perineal distance is 35 millimeters or below it, it means the head has engaged. This is an easy way of doing a head station. This is easy but accurate. During labor, do we need to do ultrasound in every case of laboring woman? No. There are certain indications. Whenever there is slow progress or arrest of labor in the first stage or second stage, and whenever you want to confirm fetal head position and station before applying instrument, and then for objective assessment of fetal head malpresentations. Sometimes you feel that it is true, you feel that labor is progressing slowly, but is it truly slow? And sometimes it helps you to identify the cause of abnormal labor. Sometimes it helps you in decision making, whether to go for instrumental or cesarean or normal vaginal delivery. And sometimes it helps you to anticipate delivery in any instrumental delivery or cesarean section. So in abnormal labor, the main aim of doing ultrasound is to identify cephalic malpresentations, deflection degree, caput mounting, direction of head descent, and the degree of internal rotation is the most important thing, and then pelvic adequacy and pelvic flow. So identifying brow and face. So by clinical examination, actually it is it needs a lot of experience. But to identify brow presentation by scan, it's relatively easy compared to clinical examination. So if you are not seeing forehead at all in transabdominal scan and only seeing orbits, then it is a brow presentation. And if you see at the neck region, you will be seeing the entire spine curvature. And if you do transperineal scan, you will be seeing the part of the orbit. So that is how you make a diagnosis of brow presentation. Face presentation, I know it's not difficult to identify face presentation by clinical examination, by palpation, you will be able to identify. But in face presentation, one thing is there will be a steep angle between the occiput and the spine like this. So next, coming to the identifying deflexed head. Because this is a cause of slow progress of labor, it is a cause of failure of instrumental delivery, and it is a risk factor of cesarean in second stage, and sometimes you will have difficulty in head extraction also, and you might have to do reverse breech extraction, etc. So how to identify deflexed heads? If it is an occipito-anterior, you have to identify the angle between the spine and the occiput. Say in this picture, you are seeing the spine is almost in continuity with the occiput. So this is a well-flexed head. Here you are seeing a steep angle between occiput and the spine. So this is a deflexed head. Coming to the occipito-posterior, here you are seeing the chin is onto the chest. There is no gap between the chin and the chest. Here you are seeing some gap, meaning it is deflexed. Here almost the entire spine you are seeing. So it means it's fully deflexed. So these are real life examples. So this is a case of flexed head. This is a case when the angle is less, if you measure angle, if it is less than 120 degrees or so, it is called a deflexed head. Here you are seeing a gap between the chin and the chest, and here you are not seeing. It is a flexed head. So coming to the head direction, this is again important. So head direction, initially when the head is descending, it comes down horizontal and then goes upwards again. So this head upward direction is a very important prerequisite before you apply an instrument. And if the head is directing upwards, most of the times it's going to deliver normally. So this is an example of head direction where it is horizontal. This is the midline of the head. This is the midline where it is going up. This is the most important aspect of transperineal ultrasound, identifying the rotation. For this you have to put the probe horizontally like this. You will be able to see the head midline like this. This head midline you have to correlate with the AP diameter of the pelvis. The closer it is to the AP diameter of the pelvis, the better the rotation. So if the rotation is less than 40 degrees or 45 degrees or so, it usually corresponds to +2, and usually you don't have difficulty while putting an instrument. So then the other thing, astigmatism, is usually seen in mild degrees, but in severe degrees it can cause dystocia in first stage and second stage. So you will be wondering sometimes, in an average size baby and good pelvis, why is it not progressing? So this is one cause why it can happen like this, and it's an important cause of failed operative delivery. This identifying astigmatism, it's difficult, I know, by clinical examination, but by ultrasound, if you are doing a transabdominal scan, you will be seeing one orbit. How much ever you struggle, you won't be able to see another orbit. That is called squint sign. So whenever you see getting into that picture, it is a astigmatism. Then identifying caput. Here again, up to this distance between the skin and the skull is called, this is the caput. So a little bit of caput can be there in normal deliveries also, but if it's more than 2.53 centimeters, then it is a significant caput, and you need to keep a watch on it. Then this is the molding. This much of molding is normal, and this molding is mild, and it usually reduces between the contractions. But look at the molding here. This is said to be a marked molding where you might have difficulty in progress of labor. And can we assess pelvic adequacy also? Yes, at the inlet level we have certain measurements, and at the mid cavity level we have certain measurements, and at the outlet we have subpubic angle. So this is a short station woman where her subpubic angle is very narrow. This is a normal subpubic angle. So coming to the pelvic floor, because everything will be normal, but sometimes the woman doesn't push, because that pushing, sometimes some women there will be difficulty in pushing. So for this we have to measure the levator hiatus, AP diameter at rest, and that maximal pelvic floor contraction. If the dimensions are less, or there is levator muscle co-activation, these are the women whom you have to teach prior how to do that pushing thing before, whom you have to give that visual biofeedback and teach them. Now predicting second stage delivery before instrument, if you need to have this combination of these things, like AOP more than 120 degrees, and your rotation should be less, and the head up direction should be head up. If you are having all these three features, then most likely it is going to be a successful operative vaginal delivery. Why do we need to do this before putting instrument? See, if you are doing a vacuum, it helps in the optimal placement of the suction cup, whether it is close to flexion point. You can try to put it close to the flexion point, and it helps in identifying the direction of the pull, and also it helps in selecting the location of delivery theatre, whether it's in theatre or in labor room, and the need for seniors assistance, because errors can happen because of deflexed or asynclitic heads. So I'll take you to some case scenarios. This is a case where second stage was like 2 hours, second stage got delayed. After 2 hours of second stage, they did the scan. I did the scan. The midline was horizontal. So what is your diagnosis? Will you put an instrument or will you take her to theatre directly for section? Or will you wait? After 2 hours, if the midline is horizontal, it means it's going to deep transverse arrest. So your first option would be you will go to section straight away. So in this case, in this second case, this is gravida 4 with previously normal vaginal deliveries. So here the second stage again got delayed by 2 hours. The reason was thought to be a big baby, but when we do ultrasound, it is an occipital posterior. You are seeing orbits here. It is a well-flexed head. Here there is minimal moulding. Caput is there, and according to AOP, it is around +1 or so. So the obstetrician was in fact contemplating to put an instrument, but after the scan, she was actually waiting for her to bear down, taking little more time, because putting an instrument and then failing and then going to cesarean would be a disaster. So waited for another half an hour, after which she delivered normally. This is a case where there was meconium stain lighter at 6 centimeters dilatation. Two registers, junior registers, have done twice PV in a gap of some half an hour, 1 hour, and they thought that the head is not progressing down, so we go for section. But look at the scan. This is at 4:28 and this is at 4:35. So in a span of 7 minutes, the head has not only gone down but has also started going up. This is a very positive sign. So mostly she will deliver normally. So after this scan, in another 45 minutes or so, she delivered normally. This is the last case which I wanted to share. This is again a patient with delayed second stage. Delayed second stage. I did scan after 2 hours of second stage. See this midline is pointing roughly posterior. You are seeing orbits. So it's an occipital posterior. This is how it appears by trans-abdominal scan. This is the symphysis pubis, and it is a well-flexed head. This is the midline. This is the midline. Head is slightly directing upwards. See, this is the midline. Occiput is towards this end. This is the caput. So when it is around, after 1 hour of doing seconds, roughly around 1.5 hours after starting of second stage, when we did this section, they actually came to know that this is an occipital posterior, but then they made her do some exercises and so, and after that they have put an instrument where, because after doing that exercises that got rotated, immediately after rotation they applied a midlow forceps and they could do a normal vaginal delivery. So this is how using ultrasound in labor room helps in your clinical decisions. So let me tell you the limitations also. We don't know how this knowledge translates in perinatal outcomes, but it definitely increases the confidence of the clinician. It fine-tunes clinical examination. It is superior in difficult cases, and it's not a substitute to clinical examination at present. So if you ask me what is the role of an ultrasound in labor, I'll tell it is like a well-trained assistant for an expert obstetrician, and it is like an experienced senior colleague for a beginner. Thank you.